We are working in a rural area in Sindh province, which is the southern province in Pakistan, and it is a province which is most hit by malnutrition or has the highest rates of malnutrition in women and children. And so we are addressing the problem of severe acute malnutrition in children between 6 months to 2 years of age. And by doing that, as you know, that in the first 2 years of life, the child is, his brain is growing, his body is growing, and scientifically it has been shown that this is the period when, if provided optimum nutrition, the child's growth, brain and body growth becomes optimum, and he can then develop his potential, mental potential. The approach that we used was to involve the government infrastructure in that areas, which would then in the future mean that there might be more sustainability. So we have a program called the Lady Health Worker Program, which is countrywide. And so we approached the government, and through them we identified the lady health workers that were working in the areas that we had targeted. We gave them the training and to be able to screen children by the mid-upper arm circumference, as is recommended in the CMAM guidelines. Now, we used a modified CMAM approach in the sense that we had the children screened by the mid-upper arm circumference, but then we had those children that were severely malnourished or wasted. We had doctors verify that they indeed were in that category by taking their weight and their length or height, and then taking out the weight for height Z-scores according to the WHO guidelines. And only those children that then fell into the category of severe acute malnutrition by weight for height, those were the children that we targeted. Now, in the CMAM project, as it is being practiced now in Pakistan, we are only using the mid-upper arm circumference. But we had it verified both ways, and by that we narrowed our target population, so it was much more manageable. After these children were verified as being severely malnourished or wasted, we gave them a high density diet that we had formulated with locally produced food, and that diet was comparable for its caloric value to the RUTF, or ready to feed therapeutic food, which is being imported into the country. Now remember, we started this project before UNICEF had started using RUTF in Pakistan. So we predated this project, and therefore we had to have a formulation that was there, that we could produce and that we could use. And we had tried this food, high density food, in other areas, in a hospital setting and also in a community setting. And therefore we felt that we were ready to try this on a larger scale. So the community loved it, so much so that the mothers wanted us to put this product in the market. They said, why don't you have it in shops so we can buy it? And it tastes so good, and it is much cheaper. In fact, they were getting it free, but they said, make it cheap so we can buy it, and it is great food for our kids because they love the taste. In fact, the mothers were also eating it. Was so good. And that produced a problem because they finished their rations before the time that was allocated for the rations. So so it was received very well. Now, did it work? Yes, it did, in the sense that we were giving 100 calories per kg per day for a child. Later we increased it to 150 calories per kg per day for a child to make up for the sharing that was going on in the family. But within 4 to 5 months, these children went from being severely malnourished to becoming normal in the WHO categorization of being less than -3 standard deviations weight for height to going to being less than -1 standard deviation weight for height. So yes, it did work. We gave micronutrients with the food. They were not added in our food, but we gave it they had to sprinkle it on the food, and these micronutrients are nationally produced. They're accepted by the National Medical Board, and they contain 7 micronutrients which are recommended. So the children got micronutrients through there, and it worked very well. Okay, so there were 2 major challenges. One, as I said, was the fact that there was sharing, and so we had to increase the rations, re-strategize, increase the rations so that the children, other children could also were going to eat it. So that was one challenge, let's say. The second one was that when we asked the mothers after the children had been screened, we wanted them to take the children to the health facility so that the doctors there could verify that indeed they were acutely malnourished and also whether they had any other complications. The mothers, by and large, refused. They said that, we cannot afford the money to take these children to the health facility, which may have been maybe 10 kilometers or 20 kilometers, unless he's really, really sick. And he may be weak, but I don't think he's sick. So unless he gets sick, we cannot do it. So they were non-affording, and we had to re-strategize and put a doctor in a team with our the project manager and make visits at the homes of these children who had been screened to verify or to confirm their status. And that was a challenge, because then we had to get somebody else into our project and then work through that. But these were the 2 major challenges. Otherwise, it went quite well. The government was cooperative, and the community was cooperative and participatory, so it went well. When we started this project, it was before the great floods hit Pakistan in 2010 and 11. And this was before UNICEF brought in the ready-to-feed therapeutic food, the RUTF, which is imported. Now, we have found that the cost of using our locally produced food, which is from indigenous ingredients, is about 1/5 of what it costs to rehab or rehabilitate a child with the imported food. And if we are to sustain this activity, because malnutrition is endemic in Pakistan, it is not a flood-related crisis. It is a crisis on its own. So when we started the project, we started with the idea that it should be scalable. Mm-hmm. And so the way we designed it was that we took the government as a partner, the Lady Health Worker Program, so that it would be sustainable and it could be replicated in other areas, since we have lady health workers in 60% of the geographic area in the whole of Pakistan. Our other partner was a local NGO that was working with microcredit, with a microcredit program. And the idea there was that we could identify the families with malnourished children and then link them up with this NGO so that they would be able to get into the microcredit program, their income would increase, and their accessibility to food would increase. Because after all, what we were doing was therapeutic. We were managing a problem that the child had, but to sustain or maintain the child's health, if the parents could not afford the food, then the child would go back, or other children would be affected. So that was the whole idea, and it is because it was with the government and because there are other NGOs and other donors working with income generation programs, poverty alleviation programs. So I feel that yes, it is scalable and it could use this model. I would like that whoever watches what we have said is able to contact me, and we would be ready to work with governmental, non-governmental organizations to cooperate and to bring this to a scalable degree. Thank you.